Good afternoon, colleagues. I'm Dr. Swart. I was at Tygerberg for about 10 years and I now moved to George Regional Hospital where I'm the head of the clinical unit of Obs and Gynae here. And I've got an interest in PMTCT and I am going to present summaries of the updated guidelines that was recently published in the second half of 2023. I also want to thank Prof. Gebhardt for all his help with this. So I based the talk on the recent ART clinical guidelines in South Africa that was published, and then we have got a Western Cape version of these, but the latest one was from 2020. So when we get the updated ones, I'll see if there's any new things that I can add. In this talk, I will discuss the goals of antiretroviral treatment and prevention of mother-to-child transmission, a bit of terminology. When we test HIV in pregnant and breastfeeding women, initiating ARVs, fixed drug combination, screening and prevention for TB and other opportunistic infections, viral load monitoring and failure, and then infant feeding and HIV prophylaxis for the infant. The goals of ART. So first we need to determine who's eligible and when to start them, how to start them, how to safety net them before starting them on treatment, and once they are on treatment, how to manage them further, how to monitor them and support them to stay adherent. And the goal is ultimately to maintain virological suppression. There are 4 pillars of the PMTCT program. The main goal is to achieve the target of HIV-free generation. So the first pillar is primary prevention of HIV, especially in young women of childbearing potential. The second pillar is preventing unintended pregnancies in this group of women. The third pillar is preventing the transmission from the mother to her infant. And the fourth pillar is providing appropriate treatment and support to women living with HIV and their children, partners, and families. So a term to take note of is a so-called dispensing cycle. In the new guideline, this replaces to prescribe medication for so-called a monthly period. And that is because months have different numbers of days in them. So the best is now to talk about the dispensing cycle, which will then be the number of days for which a client would have treatment if a single standard monthly quantity of tablets were dispensed. So when do we test for HIV? So when you see a patient and they are pregnant or they are breastfeeding and up to 1 year postpartum and they do not know their status or they were previously negative and not tested during this period, they need to be tested on the same day. So when do we repeat the tests if it's negative? So around 20 weeks, around 32 weeks, when the patient is in labor or immediately after delivery, then at 6 weeks after delivery, and while the patient is breastfeeding, we test them every 3 months. So as an intern, you will have to know these dates so that you can make sure the patients are tested appropriately. At the 32 weeks gestation, we also usually repeat the syphilis test. And then we heavily rely on interns to test the HIV during labor and make sure these tests are done. When a patient is tested positive for HIV, they obviously need to be counseled appropriately. And then we are lucky enough to live in a time when all HIV-infected women, regardless of their CD4 count, are now eligible for lifelong ARV therapy. So even when I started as an intern in 2007, we only initiated ARVs once a patient's CD4 was less than 200. So clearly, this is a much better approach. So we are lucky to be able to do that. So we want to initiate the ARVs on the same day if possible, but if you are worried about some of the contraindications to start on the same day, I will still discuss those. Then we want to still initiate the patient as soon as possible, preferably within 7 days. And we're going to discuss the medical reasons that we would defer starting treatment on the same day. So the kind of thing, so when the patient is sitting in front of you, they are pregnant and you've now tested them positive for HIV, what are the kind of things that would make you not start the fixed drug combination on the same day? So one will be if the patient has got TB symptoms, if they have a TB diagnosis at any site. So remember, TB can be neurological TB in the lungs, abdomen, or TB lymphadenitis. And you can obviously get gynecological TB as well, as you know, in the ovaries or in the endometrium. So if you have a diagnosis like this recently, then you can't just start without discussing with the infectious disease colleague. If you have a clinical suspicion of meningitis, you will also first test and treat that. Any other acute illnesses like PJP, Pneumocystis jirovecii pneumonia, or bacterial pneumonia. And then if there's a clinical suspicion of liver or kidney disease. So this would be, for instance, a patient that's jaundice or with a large liver, or somebody that tells you they are known with chronic kidney disease. So it must be quite a strong suspicion that they have this disease. Tenofovir is a treatment that we're always worried about the effect it may have on kidney function. So if you have a patient on first-line ARVs that includes tenofovir, you will then do a baseline serum creatinine, and you will then, while they're on treatment, on month 3 and 10, repeat the creatinine, and afterwards yearly. So we've got quite a monitoring system to make sure the kidneys do not deteriorate while on tenofovir. So fixed drug combination, it's been now already 2 or 3 years that we've moved to this new combination that includes tenofovir 300 milligrams, lamivudine 300 milligrams, and then dolutegravir 50 milligrams. So this regime has a lot of advantages over the previous efavirenz containing regimen that I'll list now. When we just transitioned a few years ago to this, there were discussions about the concerns regarding possible increased risk of neurotube defects in fetuses, but that has now been laid to rest, and we can now, without hesitation, switch by all patients and also childbearing women to dolutegravir containing regimens if they are not already on it. So the reason why dolutegravir is the preferred first-line ARV in South Africa is that it's superior in efficacy. The side effects are mild and uncommon. There's very low chance of resistance developing. It's cost-effective. There's less drug interaction. So the one that we were always very worried about is the fact that, for instance, as an example, the Implanon was less effective for a patient that was on efavirenz. And thus, we are very glad now that patients can be on this new regimen where you can still use Implanon contraception. And lastly, it's very safe, and that neurotube defects are no longer a concern that will influence your regimen of choice, as I mentioned. So there are a few drug interactions to remember with dolutegravir. The first one is that the following drugs decreases the efficacy of dolutegravir, so you must thus increase the dolutegravir dose. So it's rifampicin, so TB treatment, and then anticonvulsants, carbamazepine, phenobarb, and phenytoin. So if you have a patient on these, you will have to discuss with internal medicine or ID regarding the dose increase of dolutegravir. Then something that we see quite often in obs and gynae is patients on metformin, and metformin becomes more effective, or the concentrations increase, and thus you must be careful not to overdose the patients with metformin if they are on dolutegravir. And with overdose, I mean that you that you use more of the drug than is safe. So the maximum metformin dose when a patient is on dolutegravir is actually 500 milligrams 12 hourly, and not 850 3 times a day that we put patients not on dolutegravir on. Also important to note that if taken with iron supplements that we commonly prescribe in pregnancy, it must be noted that you must take it with meals. So if you have the patient now in front of you that is now diagnosed HIV positive during pregnancy, and you don't see any obvious contraindications to start her or defer her initiation of first-line therapy, there's quite a lot of tests that you want to do at that first visit where you now made this new diagnosis of HIV. So one is the ELISA, a CD4. The CD4 will be for a few reasons. The one is that the lab automatically does a cryptococcal antigen test if the CD4 is less than 100. The other one is that it will also guide your Bactrim prophylaxis for PJP. So if the CD4 is less than 200, you want to initiate that Bactrim. And then it also guides whether we're going to give INH, isoniazid prophylaxis for TB, but I'll get to that. You also want to do a full blood count. That is because HIV itself can cause bone marrow suppression with anemia and thrombocytopenia, but also if you're on ARVs, it can obviously cause that the treatment can also cause those problems, the HIV itself and the treatment. So you want to know the baseline full blood count. Creatinine, as I mentioned, also to do with the tenofovir. Liver function is always important to know the baseline ALT because, as you know, ARVs and TB medication, some of the most common problems that they develop is so-called DILI, drug-induced liver injury. So drug-induced hepatitis because of the ARVs is not uncommon. Syphilis test we do routinely in pregnancy. Hepatitis B surface antigen, very important in South Africa. It's recommended for all HIV positive patients because there's an increased risk of them having hepatitis B as also a sexually transmitted disease, and particularly in pregnancy, it's very important because with you can prevent that hepatitis B to go to the fetus and to the baby, and we know that when a baby gets hepatitis B already at birth, that can often result in liver cancer diagnoses in a young age, like maybe in your early 20s. So it's really something you want to prevent. Like I said, the lab reflexively do the cryptococcal antigen if the CD4 is less than 100. If the viral load, well, in this case, you will do a viral load because you won't have a baseline viral load. So pap smear in pregnancy. If the patient has a new diagnosis of HIV, you must do a pap smear even if the patient is pregnant. And they talk about sexually transmitted infection screening. So that will be questions like, do you have any genital discharge or ulcers? And if the time allows to have a look for that. And then another screening question will be, have your partner been treated for an STI in the last 8 weeks? And then a very important part of antenatal care that we've been highlighting recently, but also part of the ARV guideline, is that we must screen for active depression and mental health and substance abuse issues, because this will obviously influence your compliance on your medication. Screening for TB. So TB is very, very common. And pregnancy and breastfeeding women are more at risk for TB because they are immunologically suppressed. So it's very important that we are always actively looking for TB and thinking about it. So at every visit, we should screen pregnant women for TB symptoms. And then all women who are HIV positive and pregnant, whether it's old or new, should get a sputum sent for gene expert. According to the guideline, that gene expert result must first be negative before we initiate ARVs. In practice, I don't know if we always do that, but if you have any index of suspicion of TB or the patient is particularly at risk, looking chronically unwell, it would be best to first get the gene expert result before you initiate it, but otherwise you can initiate ARVs and get the gene expert result as soon as you can. So the type of symptoms that you're looking for would be cough, especially if there's productive sputums, fevers, drenching night sweats, weight loss, tiredness, shortness of breath, chest pains, and new palpable lymphadenopathy. So I myself had TB when I was a registrar, and I always sort of like to tell stories of things that happened to me. It makes it more memorable. And for myself, I developed a pleuritic chest pain. And I walked with that chest pain for many weeks, thinking that it was a muscle injury because of coughing or because of exercise. And it took quite a while for me to eventually be diagnosed with TB. So don't think the patient will just offer you that symptoms. It's sometimes quite a journey to get to the diagnosis. So other TB tests except for gene expert on sputum that is available is a urinary lamb, and that they recommend if the CD4 is less than 200 or you've got more advanced HIV. So this will be more in the context of a more seriously ill patient that maybe cannot produce sputums. And then you can always also do things like a chest x-ray and extrapulmonary TB testing, but that is not routine. The screening is definitely, first line for screening is definitely the sputum gene expert. So TB preventative therapy, TPT. So the current guideline states that all pregnant and breastfeeding women should get INH 300 milligrams daily and pyridoxine 25 milligrams daily. The pyridoxine is to prevent the neurological side effects you can get from INH, and that all women that are pregnant and breastfeeding must get this for 12 months. In practice, that is not being applied, and I had a discussion with Prof. Gebhardt recently again, and he said that there's still ongoing discussions whether that is going to be implemented practically. So until we know the results of those discussions, I think definitely if you have a patient with a CD4 less than 200, I would consider initiating the INH prophylaxis. Before you initiate the TPT, of course, you must have the negative gene expert, and be aware that there are also contraindications for INH. For instance, somebody that's got active TB and liver disease, alcohol abuse, and maybe hypersensitivity to INH, so that you may be allergic to INH. Like I mentioned, the cotrimoxazole or the Bactrim prevention. So that we start if the disease obviously we want to prevent is PJP, or the old term is PCP. We started if the CD4 is less than 200 or if the patient has a World Health Organization stage 2 to 4 disease. So it's important to have a good idea about the WHO clinical staging, because it's not, you don't need special investigations. It's just a little table that gives you the idea of when you have a clinical symptom, for instance, esophageal candida or specific weight loss, skin rashes, that you can already upstage the patient based on that. And you will then stop this prophylaxis once the CD4 is more than 200, as it may cause hepatitis, so you don't want a patient to be on it unnecessarily. If you see a patient, and this may happen to some of the interns in the labor ward, that's now only diagnosed with HIV during labor for the first time, then you must give them a stat dose TLD as soon as possible and a stat dose nevirapine orally, 200 milligrams. And the next day you can then initiate them on lifelong ARTs as we've discussed. And of course, contraception is very important, and dual method, so that means preferably long-acting contraception plus a barrier contraception is always the best. So that will be a condoms use that will be the best for females living with HIV. Viral load monitoring during pregnancy. So the Western Cape document has, and you can Google that document, so it's not difficult to get your hands on it. They've got a nice flow chart on how to monitor viral load during pregnancy. But I think the most important part is that you must understand that if you start ART before 28 weeks, then you've got a few months to get the patient's viral load down for the sake of the baby, right? But if you only initiate it after 28 weeks, your time is limited. So we must have sort of a more aggressive viral load monitoring and upscaling of the ARVs. So if you start before 28 weeks, then you can have the first viral load 3 months after you initiated the treatment. And if the viral load is more than 1,000, you must look for reasons for that. Usually the most common cause is adherence issues. If you've addressed that, you can then repeat it again after 3 months. And if it's still high, you can then consider second line ARVs or genotyping to look for resistance, but that must always be discussed with the infectious disease consultant. If you initiate ARVs only after 28 weeks, you don't have a lot of time, so you will actually review the patient in 2 weeks' time. And then you will repeat you will do the viral load then after 2 weeks on treatment. And if it's less than 50, that is then suppressed, and then you only need to do it again in delivery. If it's between 50 and 1,000, then you can do the adherence counseling and repeat it after 2 months. And if it's then more than 1,000, you need to then, if there's time before delivery, you can then do another adherence counseling session, repeat it after 4 weeks. But if you are close to delivery, you need to then consider going to second-line therapy or doing genotyping to look for resistance. But like I said, that you will never do without discussion with a senior physician or an infectious disease consultant. So there's also a specific viral load monitoring algorithm in the Western Cape Department of Health document. So how to manage viral load in a HIV positive patient that's breastfeeding. You want to aim for a viral load less than 50, and you need to repeat the viral load every 6 months while breastfeeding. And it also addresses what to do with viral loads that is not suppressed. So what is virological failure? So when I was a more junior doctor, we used to diagnose it quite quickly, and then junior doctors could actually change the patients to second and even third line ARVs. But now we've moved away from that, because especially now with the dolutegravir containing first regimen, resistance is very, very rare. So it is almost always adherence issues. So it will be inappropriate to now change the patient to other medications. So the definition of virological failure is that you must have 2 or more viral loads more than 1,000, and it must be taken more than 2 years after starting dolutegravir containing regimen, and your adherence must be more than 80%. And like I said, the resistance to dolutegravir is very rare. And then there's a section in this document that's called EAC, Enhanced Adherence Counseling. So I would recommend that you read that, because in the end, we don't all have access to HIV counselors, and we all play a role in this more intense adherence counseling. Often it is patients that have very legitimate reasons, for instance, side effects, and access to food and access to care. So we can't just presume the patient is uncooperative. No regimen changes may be done without a resistant test. So that is that genotyping tests I spoke about. But in the new guideline, it clearly says that this can only be authorized by a member of the National Third Line Committee, helpline consultants, or nominated provincial expert. So this is definitely not something that most of us will be able to do. So once you get to the point where you actually think there's virological failure, you need to escalate it to quite senior colleagues. So never change the patient to other ARVs on your own account. So this is a table just summarizing the causes of elevated viral load. So it's A, B, C, D, E. Adherence is the most common. And then bugs, so there can be co-infection with other STIs or TB. Is it the correct dose for their weight? This is especially important when you're dealing with growing children. Always think about other drug interactions. For instance, if the patient's on anti-epileptics, rifampicin, those often have effects. And then the last one is resistance. So resistance, the very last one, and like I said, we should manage this option with care. So other indications to discuss either with infectious disease or with a senior physician would be if you have got kidney affectation, either baseline or it develops as you are continuing your tenofovir. If the patient has a psychiatric illness, if they have poor response to TB treatment or suspicion of iris, and if they have a change in clinical state while they're on ARTs. And basically, if you have doubts and questions, then you should escalate it, because it's actually quite the expert field and there's a lot of changes that happens all the time. So it's difficult for somebody who doesn't work, particularly with HIV, to keep up to date with all the changes. Very, very important is infant feeding. So the guideline recommends 4 or more counseling sessions antenatally about infant feeding. So there's lots of myths and wrong information about infant feeding in patients who are HIV positive. So firstly, we as doctors should make sure that the patient is very clear about it, that breastfeeding is safe in HIV positive patients as long as they are following the treatment guidelines and the baby is on infant prophylaxis according to the guidelines. So breastfeeding for 2 years is recommended, even if the mother is HIV positive. When I was a young doctor, once again, there was a few months and years when the thought process was that when you mix feed the baby, at any stage, they should stop breastfeeding because the chance of transmission of HIV is now very high. And this is now not being proven to be the truth. So although we support and recommend exclusive breastfeeding for 6 months, and to introduce solids after 6 months, if the baby has another caregiver or for whatever reason the baby is getting other food, that is absolutely okay, and the baby should continue breastfeeding as well, as long as the mother and the baby is on appropriate treatment. The only real indication for formula would be if the mom is failing regimen 2 or 3, that means she's been using it for 3 months and her viral load is still unsuppressed, or if the mom is physically too sick to breastfeed. So if the mom has a new diagnosis or a high viral load, or she's not compliant, or she's on other treatment, all of those indications, they can still breastfeed. There's very few drugs that's really contraindicated in breastfeeding. One, for instance, will be chemotherapy for breast cancer, but it really is an exception. If a mom says she chooses formula, it must be despite the fact that she understands the safety and advantages of breastfeeding. The mother must have safe water and sanitation. She must be able to afford formula. It's expensive. And she must have family support and be able to provide it safely. For the sake of this talk, I'm not going to go into the detail of infant prophylaxis, but the important thing to understand is that a change in the 2023 guideline is that all babies are started on dual therapy after birth. So all babies of mothers that are HIV positive, it doesn't matter what their viral load is before they give birth. So they start on AZT and on nevirapine. Then the viral load that we have now done during labor is checked. And if that is suppressed, then the baby only needs nevirapine for 6 weeks. If the viral load is not suppressed, they will then continue with dual therapy. And then obviously as the risk increases, sometimes the ARVs will be given for a longer period of time. But in a low risk mom where the viral load is suppressed, she will then the baby will get dual therapy until the viral load is out. And after 2-3 days, if it's out and it's less than 50, the baby will only continue with nevirapine for 6 weeks. After that, as long as the mother is drinking ARVs, and the viral load is suppressed of the mother, the baby can mix feed and drink breast milk, etc. safely. So the idea of that first 6 weeks is that the baby's gut is at particular risk then for the HIV to be transmitted. So we cover that first 6 weeks even in a low risk patient. So the patients will heavily rely on us to give them the correct information because, like I said, there's lots of wrong information about this topic out there. And then lastly, on the guideline, there are numbers that you can call if you have any doubt that for help and support if you don't find it in your local hospital. Thank you very much, and I recommend that you all get your hands on the guideline. It's free on the internet, and read it and all be champions for HIV treatment and PMTCT. And from an obstetrician's point of view, obviously, especially in the pregnant and breastfeeding women. Thank you.